Huh? Just lock it, lock it. That is the normal way it's locked.
Hello, good evening, everyone. Please, can you confirm if you can hear me?
Loud and clear. Good evening, ma.
Okay, good evening, everyone. Trust our day went.
Yeah, hear you, ma.
All right, thank you so much. So it's almost 8:30 and we just have 29 of us here, which is not a good number. So please, if you have a colleague or a friend that is meant to be in this class and is not yet in the class, please can you send a message to them and tell them to join the class, because our facilitator for tonight is already in the class. So please tell them to join in.
Hello?
Please, can we kindly mute our mic? If your mic is on, kindly mute it. Okay, so I think we can start now. All right, so our facilitator tonight is Dr. Zainab Abdulrahman. Ma, please, I don't know if I pronounced that well, forgive me. So I don't know if you're ready for us tonight.
Yes, but you might need to share the slide yourself. Good evening.
Oh, all right. Okay, okay. All right, ma. Let me look at that. Okay, ma, please give us some minutes. My co-coordinator will do that. So I think she's trying to set it up, but once it's up, she'll let us know.
Okay, that's all right. Okay, I'm able to do it, but I'm not on the laptop. So we might just take it on the phone like that.
All right, ma, you can go ahead.
Oh, okay. So good evening, everyone. I'm Dr. Abdurrahman Zainab, and I'm going to be talking about task levels for rehabilitation in primary healthcare. Even though we're going to be talking about primary healthcare, we're going to try and relate to regular clinics, and then we're going to also talk about the service delivery platforms that are available. So basically, rehabilitation is a component of universal health coverage. And together with health promotion, treatment, palliative care, and disease prevention, universal health coverage is also is aimed at ensuring individuals receive healthcare services without financial hardships, and it's a target of the Sustainable Development Goal 3, which is aimed at ensuring healthy lives and promoting well-being for all at all ages. So it's all, and for it to be successful, there has to be provision of all of these 5 components within the primary healthcare. So according to WHO, rehabilitation is a set. Can you hear me, please?
Yes, ma, we can hear you now. Go ahead.
Okay. So, and rehabilitation is not just for people with diseases. It's also for people that have impairments to be able to live without any handicap. So whether a person has maybe visual impairment, rehabilitation will ensure that he could be able to do everything for himself. For example, he could be given some visual aids, maybe glasses, or if he's completely blind, he could be given maybe an assistive device, a stick with some kind of sensory input where we'll be able to know where he's going, or a stick that would have some auditory, where he will use auditory input to be able to know how long he has to travel to get where he wants to go, and that limits his levels of handicap. So rehabilitation actually ensures that we're able to live successfully. And then the interventions provided in rehabilitations, it's actually carried out by various professionals or various cadres of health workers. We can have physiotherapies, occupational therapies, rehabilitation nurses, and even community health workers, if we want to integrate into the, when it's integrated into the primary healthcare. So within the context of primary healthcare, it's expected that it's in the primary healthcare that we can see many disease conditions, because it's actually the platform that is closest to the community. So they're able to bring basic essential services closer to individuals. So rehabilitation within the primary healthcare is actually given at various levels, because it will depend on the person's training. The care that he provides will depend on his training. So rehabilitation in primary healthcare is just aimed at reducing hospital dependence, people going to the larger hospitals. It's aimed at reducing people going to the frequency of going to larger hospitals. It's aimed at promoting early intervention, because you can actually catch those conditions early, because there are various conditions that they see there that you might not even get to see at the general hospitals or except on referral. Then it's actually is a place where they can enhance functional recovery of individuals. But sometimes, and most times, what is obtainable is that there is workforce shortage, and professionals are not enough to be deployed to these primary healthcare centers. So we have to have general practitioners or lower cadre healthcare workers that have training to be able to identify when there is functional limitations and refer to appropriate higher centers. So this group operational could be primary care nurses, they could be community health workers, or rehabilitation assistants where available. So when these people are there, they actually, if they do not have training for physiotherapy, they should be able to identify where there are needs in mobility or function and refer to the appropriate authority. For example, in the primary healthcare, I said that tasks are shared based on one's training and based on the training that is available. So there are various cadres of healthcare workers within this platform of care. We could have community health workers. Community health workers could be able to screen and identify that this child or this patient, this person has a problem, has a limitation in functional mobility or something, and then they are going to be able to identify that this person has a problem and refer to appropriate person. It's expected that within the primary healthcare, there are primary care nurses. Their responsibility is also early detection, to be able to detect that this person has a mobility problem. Then where it's applicable, there could be trained assistants to any of these rehabilitation professionals. And these trained assistants, their responsibility is also to be able to detect and to be able to carry out implement simple exercise protocols that would have been prescribed by the professional, as in that professional that is a specialist in that area, that it could be an occupational therapist, a physiotherapist, or any other rehabilitation professional that the condition refers. So then within the healthcare, the primary healthcare, there's also supposed to be a professional. That person could be a physiotherapist, an occupational therapist, and their responsibility is to do assessments and prescribe exercises or whatever modality that needs to be prescribed to the patients. And then they should supervise those people that are carrying out these simple exercises. There's a limit to what the professional will do within the primary healthcare system. And if that patient that he has assessed requires more care, then he will send them to a higher service delivery center. Then the medical officer that is within the primary health care is actually in charge of coordinating all these multidisciplinary activities within the center. That's about primary health care. But primary health care is only the first level of care. So there are about 4 service delivery platforms in the healthcare system. We have the outreach, where people can just go into the community and provide some certain level of care to individuals within the community. It's very limited, but it could just be an assessment or a group exercise program or an education. But there's that outreach, which is the first, which is also a level of care. Then the first level of care is the primary health care, where whatever kind of condition the person has, it can present to primary health care, and at that place, there's going to be coordinated activity to either refer out or see and prescribe, and Then the second level of care is where, when a patient cannot access care at the primary health care because it requires more than they can give, then they refer out to either secondary hospitals, that's like general hospitals, other referral centers, maybe private hospitals that might have some special specialty that they do. Then the third level of care are the tertiary centers, and then hospitals that are dedicated to a particular specialty, like the national orthopedic, the neurological centers, and they all fall under tertiary care centers. So across all of these platforms, task is shared into layers based on an individual's competency, hierarchy, and training. So I can give you an example of this, maybe in a hospital setting, a general or tertiary hospital setting. We could say that the first task layer could be activities that interns, core members, and basic level professionals would carry out. For example, they could be the ones that would do a clerking and identify what is wrong with the patients, and probably just identify and probably do some assessments. And then when they are not able to make a decision, they will go to the second task layer. This could be people on a senior cadre, principal, or chief, and they could do more intensive assessments to be able to reach a proper diagnosis. If it goes beyond them, they would now go higher to the third level, third task layer, which could be the directorate cadre, and they will be able to probably do more intensive assessments to be able to reach a proper diagnosis for that patient. And basically, that's how tasks are shared according to that's how tasks are shared across the platforms of care. But this is just a basic example of hospitals. So before we go into the task sharing, it's good to note that interventions.
Intelligent, very intelligent.
Very lazy.
Hello, Ma, we can't hear you.
I
Think we lost her. Hello, Ma. Hello, Dr. Zainab, can you hear me? We can't hear you.
I'm sorry, it took me out.
Okay, Ma. Welcome back.
Yeah. Let me just put it back up. So there are about 23 rehabilitation domains that were postulated by the WHO, and they actually include cognitive, visual, hearing, motor functions. Just like that, it's on the next slide. There are about 23 domains, and they also developed packages of intervention for various conditions. And on these packages of intervention, they identified the rehabilitation domains, and then the functioning domains, and then they also identified assessment to be performed for each of these domains, and then the various professionals that are responsible for those tasks. So that is what they had developed. And these are the domains of intervention. So coming down to the primary healthcare, considering all those cadre of staff that I've highlighted, the community health workers, the nurses, the trained assistants, the professionals, and then the medical officers, task is actually divided across these people based on their capabilities. So at the basic level, which is task layer 1, we have staff that are trained to actually just identify. They can screen to identify that there's a problem. So they provide services at the very basic level. For example, the community health workers and the nurses, they are the kind of people that are actually trained to just identify that this person has a problem. At task layer 2, we have that professional, maybe a community physiotherapist or somebody, that professional that can actually assess to see that, yes, this is the problem, and he can actually prescribe the treatment plan and develop an exercise program or something like that. At task layer 2, that is what this professional is supposed to be. He has to be a professional that can actually assess and develop a treatment plan. At task layer 3 goes beyond what this second professional can do. It could be based on hierarchy, that person has more experience, that this community health worker is also a professional within that field of condition that was identified, but is a specialist. And then once there's something that the person at task layer 2 cannot do, he's called in to do it. And if the scope of activity goes beyond what should be provided in primary healthcare, which is just simple exercises and education and a few assessments, then you refer to a higher platform, maybe a general hospital, or depending on the condition, a tertiary hospital. So here I have a few examples of what task is like within this the primary healthcare. What tasks should be like within the primary healthcare. The first example is on interventions for motor function and mobility domain for a patient with Parkinson's. Remember, I told you that they develop packages of intervention for various conditions. So this was picked out from what was developed for Parkinson's disease. So interventions for motor function and mobility domain in patients with Parkinson's disease. So at task layer 1, when this community nurse or community health worker actually sees a patient, they should be able to identify that probably this person has a problem in movement. So going forward to the task layer 2, he should be able to assess that movement limitation, and he should be able to assess the muscle function. Then at task layer 3, that person should be able to assess balance. As a matter of fact, assessing balance will come under task layer 2, but going deeper into how the balance probably affects the individual and assessing fine movements, gait pattern could be from somebody at task layer 3. I don't know if I made any sense. Hello?
We are with you, ma. Yes, ma.
Okay, so I said, I don't know if I made any sense with that. This example of interventions for motor function. Okay.
Yes, it makes sense. It's just increasing the difficulty.
Yes, as the difficulty of task, yes. Then you require a person with more training to be able to do that. So even in the primary healthcare, you should be able to do most of these activities. The untrained person, that community health worker or the community health nurse or something like that, should be able to tell that this person has a problem. Then at task layer 2, we have the physiotherapist, a community physiotherapist or somebody, and that person should be able to do assessments across movements, muscle function, bone, as in assessments like check range of motion, you check muscle strength, then you want to see bony alignments, you want to see posture. At task layer 2, they should be able to do all of that. At task layer 3, you want to check balance, you want to check fine movements, you want to assess gait. And then more detailed assessment comes out of task layer 3. Then another example for interventions for speech and language, interventions for speech, language, and communication. For example, in a patient with cerebral palsy, that was another package of intervention that was developed. It's at task layer 2 that they can do all the assessments. Task layer 1 might also be able to identify or not, but it's at task layer 2 that the person can do a proper assessment of a patient with speech language problems. So you require a professional to be able to assess that. Then for activities as interventions for participations in patients with traumatic brain injury, that's another package of intervention under PIR. For traumatic brain injury, is also a professional that should be able to do that. So there is actually a limit to what that person at task layer 1 can do, even within the PHC. We have to have a professional on ground to be able to assess properly and determine if the patient can be seen in the PHC or if the patient has to be referred out to a higher platform. But most importantly, we also require, amongst this tax layer 1, we require that there is somebody that is trained enough to be able to carry out activities. Remember, primary health care actually brings services closer to individuals and communities so that they don't have to depend so much on higher hospitals. And then those higher hospitals that are referral centers should be handling cases that are more difficult to handle for the PHC. So there has to be somebody that can institute simple exercise programs and teach teach ambulation with assistive aid. There are a few small things that has to be done within the PHC, and there has to be somebody that is trained to do it. Maybe a community health nurse, maybe a community health worker, or maybe a trained physiotherapy assistant. So basically, tax layers and rehabilitations across health delivery platforms is determined by a person's training and competency. Thank you very much for listening to me. So I will take any questions.
Okay, thank you so much, Ma. Thank you, Ma. Thank you for the class. Yeah, it's just straightforward and explicit. Let me just use that word. Thank you, Ma. So please, I will take questions. If you have any question, please, since we have more time, we can take 5 questions. So please, can you signify by waving your hands? Raise a hand. Raise your hand. Use the emoji to signify that you have a question. Okay, you don't have any question?
Well, it's actually straightforward.
But I'm raising my hand though.
Okay.
I'm also raising my hand already.
Sorry, it was an oversight. I didn't see the hands. All right. So, Mr. Suleiman, let's take your question, please.
Good evening, Ma. Good evening, moderator. Good evening, everyone. Thank you very much for this straightforward presentation, Ma. Where I just need clarification is with respect to, as you said, in the primary health care, the tax layer 1, the activities there is going to be carried out by trained either nurses or community health workers or rehabilitation assistants. So that the issue of that training, is there any specific maybe certification or school or where they can go to get that training? Or is it the responsibility of we, the rehabilitation professionals, to make sure we give them such type of training? Thank you very much. I just hope my question is clear.
Very and hard. Okay. The second question, please. I should go ahead and answer this.
Yes, Ma. Answer the first question.
Okay. So what you're asking basically is if there's any way to train these people, or if as professionals we're meant to be the ones to train them.
Yes,
Am
of
I
course,
clear?
Ma.
Oh, okay.
Yes, ma'am.
Okay.
Of course.
So right now, I don't think that there's training for them. So, but if we want to, I don't know. I don't know if the board, I think the board is starting a training. I don't know if they have started or not. But what I know is that since we want rehabilitation to be integrated into primary healthcare, those community physiotherapists that visit such centers would have to be able to teach them to identify. Because here in Kwara State, where I am, we have community physiotherapists that actually go to primary healthcare centers that are affiliated to our hospitals. So basically, they actually explain to the nurses or community health workers that are on ground what they need to refer to them. what they need to see to be able to refer to them. So maybe we'll have to start somewhere before whatever training that is available can be made. But without training, they can identify, but without training, we cannot prescribe exercises for them to do. I don't know if I make any sense.
Yes, ma. Thank you very much. It's clear. I understand.
But basically, I cannot
Mm.
answer that. I know there is a lot of controversy about the training and no training. But what I know is that what we do in our center is that the community physiotherapists that go to these centers that are affiliated to UICH, they actually just intimate the nurses and educate them on what to see and send.
Okay.
And then even there's a limit to what they carry out in the PHC.
Okay.
If, for example, because we have specialty in physiotherapy, if, for example, they meet a CP case, they are community physiotherapists, they cannot give the best to that CP case. So they refer them to our center to continue their treatment.
Okay. That's nice. Thank you very much, ma'am.
Ideally, what the PHC should be is that, for example, if a patient had a fracture, it has been managed, we can refer them back to the PHC to learn how to ambulate. We can actually send them back to the PHC for simple strengthening exercises. That is what is supposed to be obtainable in a PHC because we want to bring healthcare closer to the people.
Exactly.
But if there is no training, then there is no how we can achieve that completely.
Okay. Thank you very much, ma'am.
Okay, you're welcome.
All right, Mr. Ridwan, you can go ahead. Mr. Ridwan, you can go ahead with your question.
Hello, good evening.
Okay.
Good evening.
Thank you very much for this presentation. It's quite eye-opening. And it gives direction to how we can maybe gauge yourself. Okay, what are the things, my competency level now?
Exactly.
Am I at tax layer 1, tax layer 2? Am I able to do the activities that are required of me in each tax layer? However, I would like to know if there is a reference I can go to so that I can be able to know, okay, based on my competencies, I can operate at this activity layer or tax layer. Is there a book that specifies what you should do at tax layer 1? Just like you mentioned, these assessments, is there like a reference that we can use to know which assessments should be able to fit? Okay, if I do this assessment, I'm fitting into maybe just the first layer, second layer, third layer.
Actually, what I used to develop this write-up was a classified document from WHO. It was rather a working document, so it's not readily available to people. You understand? I had my boss was actually my boss was part of the people that actually the peer group that actually developed the PIR for the cerebral palsy. So I had their working document to use, and the working document is what identify what is available for across each task layer. So specifically, I did not research deeply to find what will define activities at this task layer, what will be the activities at this task layer, what will be the activities at that task layer. Well, all I was able to gather from the summary of that document was that at task layer 1, they should be able to screen, identify, and educate, and carry out simple exercises. Then at task layer 2, they should be able to assess and prescribe, and then coordinate the activities of task layer 1. Then at task layer 3, they should be able to carry out more refined assessments. Probably if at task layer 2, you can do cognitive assessment of finger to nose or something like that. I'm sorry, coordination assessment of finger to nose or something like that. Then maybe at task layer 3, there should be something else that you can use to determine what is actually causing that coordination issue that the patient has, or maybe there's further assessments that they can do to be able to determine the severity or something. I don't know.
Yeah,
I did not come
yeah,
across a document that
yes.
could tell me
Thank
all
you.
that. But this is
Because
basically
I'm with you, sir.
what I was able to. This is basically what I was able to get. But it was a working document and it's not readily available. I don't even have it. I even had to use his laptop because he said it's a legal issue if he shares it out. So he cannot release the working document.
Because the reason I ask is because
Mm.
these things you mentioned, they are actually things that we need a backing document. It's quite robust, and if I
Yeah.
could get the reference, it will help me in structuring or canvassing for structuring of rehabilitation services. Because
I can actually
the
get back to you on this. I will find out from my boss and see. Then I will send it to your group guide. If
okay,
I'm able
ma'am.
to get anything, I can get back to you on this. I'll find out from him if there is any other document that was given by WHO, or maybe you can actually go into the WHO portal and find and check.
I will actually look for, and I can't find. That's why
You can't find anyone, but okay. I
yes,
actually
that's
got it
why.
directly from their working documents, and they must have had a guide to be able to determine what goes to tax layer 1 and what goes to tax layer 3. So I'll find out from him if there is a guide that they used.
Thank you very much. And I would like
No
if
problem.
they can, if you can also talk to WHO, a lot of the documents they use, especially for this new thing that we are doing in rehabilitation, a good number of the references we need to actually domesticate a lot of these things are still classified. For instance, the
Okay.
rehabilitation competency framework, the
Yeah.
interventions, we just have a broad overview of what intervention
Should be
should look
done.
like. But
Okay.
what we are supposed to be going towards SOPs and guidelines
Yes.
and
Yes.
things like that. So, and those are documents that we need to actually be able to talk to
Guide
the people
developing
that
our own contextually, right?
our own context and policy.
Okay. Okay. Okay.
So thank you. I will be hoping that you can help us in this. And
Whether I can get or not, you get a feedback.
okay,
Yeah.
thank you.
Thank you. Yeah.
All right. Okay, ma, we have a question.
Yeah.
Can you hear me, ma?
I'm with
Okay,
you.
someone asked the question. It says, I would like to know if the PHC healthcare personnel would have prompt responses from other professionals in tax layer 2 and 3. And she also said, how about the professional rivalry problem in Nigeria, where a particular set of healthcare providers believe they had the monopoly of patient management?
If the PHC healthcare personnel would have prompt responses from the other professionals in tax layer 2, who is the PHC healthcare personnel? Are you talking about the community health worker and community nurse? If you are talking about them, then definitely, if that center actually has a professional at task layer 2, he will respond to them. But it's not, right now in Nigeria, it's not every center that has that professional attached to it. So as long as there's that professional at task layer 2, he will respond to them. If not, it's the medical doctor that is coordinating the activities of the PHC. And yes, in the PHC, the medical doctor is one that is conducting the activity. So I don't know about this monopoly or monopoly of patient management. Yes, there are healthcare professionals that try to hold on to, but within the PHC, it's not like when you go to the ward, the nurse is in charge of all those patients. So when you go to the PHC, it's the doctor that has the monopoly of. So it's a PHC thing. It's not, it's when you come to the higher level platforms that you start to say you want to do multidisciplinary, you want to do transdisciplinary and all that. So in the PHC, the doctor is actually in charge of the whole, when you look at the organogram, the doctor is in charge, and rehabilitation cannot stand on its own. It has to go into the organogram of the PHC. So that monopoly will definitely be there in the PHC. But as long as there are professionals attached to that centers at tax layer 2 and 3, there will be response. But it's just starting out in Nigeria, and we don't have everything on ground. Is that all right?
Okay, ma. Dr. Inyukumere, please, your question be answered because she was the one that asked the question.
Okay.
Can answer for herself. I don't know if she's here.
Okay.
Hello, Dr. Inyukumere, can you hear me, ma? Has your question be answered? Or do you need more clarification on it? Okay, she said yes.
Okay. Thank
All
you.
right, thank you so much. Please, do you have any other question, area of concern before we call it a night? All right. Okay, so in absence of any other question, please can we appreciate our facilitator for tonight? Thank you so much for your time and
Yeah, thank you for having me.
you're welcome, ma.
Thank you, ma.
Yeah, thank you.
Thank you very much, man.
Yeah, thank you very much. So
All right, thank
I
you,
can.
ma. Thank you very
You're
much.
welcome. Thank you. Yeah. So, okay. Good night.
All right. So before we all leave,
Good night.
okay.
Yeah.
All right. So before we all leave, let's welcome Piti Dera Eleke. So she will give us more info about the quiz for tonight. All right, Piti Dera, you have the floor.
Thank you so much, Victoria. Good evening, everyone.
Evening.
Good evening, Dara.
Okay, I really appreciate us all our efforts so far. With all the efforts we've been putting in so far into the training. So I'll just be dropping the link to tonight's quiz here on the chat box. Please, I would really encourage us to. So from here now, the coordinators will share it to YouTube for those that might be viewing from YouTube. So I would really encourage us to try to copy the link and keep it safe just in case maybe something happens because it will not be shared in the group chat. Thank you, everyone.
All right, thank you. So please copy the link and answer the question. So that will be it for tonight. Thank you so much, everyone, for coming. Have a good night rest.
Good night, Victoria.
Good night, ma. All right, the class has ended though. We can all leave now. We can leave now. The class has ended.
Da ka dawo.